have a couple of questions.
Sure.
Does anyone else have a question right now? I don't see any. So I have a couple of questions. And
One at a
so
time.
are there any other ways to take PrEP right now other than taking it daily?
No, not
So
for women. Not for women.
Right.
There are for men.
Exactly.
So
Right.
so this talk was obviously geared towards cisgender women. For both transgender women and for men who have sex with men, there's what they're called PrEP on demand, which is a 2-1-1 where you take 2 PrEP pills before exposure and a pill a day for the 2 days to follow. And so it's a much easier regimen in that you aren't required to take it for quite as long. For women, because of differences in tissue penetration, the way the drug concentrates in the tissue, we know that women need to be on the drug for 3 weeks leading up to the exposure and then for 30 days after an exposure. So unfortunately, the way the current drugs work right now, they just don't work quite as well for cervical vaginal tissue. What about, sorry, I'm just saying a question. What about for trans men? They only, correct. So actually I don't want to say correct. I want to say the assumption is that it's only a daily option. We unfortunately really don't have the data. Let me back up. We have the best data in white cisgender men who have sex with men. We have some data in transgender women who were included in those same trials, but a lot of the transgender women that were included in those trials were not necessarily on gender affirming hormone therapy. So it's unclear if PrEP is quite as effective and if there's any issues for transgender women who are on full dose estrogen therapy or for transgender women who are having neovaginal receptive sex, meaning transgender women who have transitioned and are having sex in the vagina. For trans men, I've seen next to no literature. My presumption is that it would depend on the kind of intercourse a trans man is having, but I would assume that the statistics would be pretty similar to cisgender women, but unfortunately, there has not been a push from the pharmaceutical industry to study PrEP in transgender men. And so we just unfortunately don't have that data. So it's mostly extrapolation and expert opinion.
Do we have other questions from the group? I have another question. I know in a lot of the original studies, most of these studies were all based on using PrEP, but also using condoms, right, in the studies. And is this a case for the future studies as well? Is that going to change at all?
So the original studies, the earlier studies were all PrEP versus placebo.
Right.
And they handed out condoms. We know that condoms are a nice thought, and we know that condoms do work reasonably well when used. We also know that realistically, most couples don't use condoms and don't always use condoms the way condoms are meant to be used. Doing a placebo trial is no longer ethically acceptable, given that we know how well FTDF works. So you may have heard me mention the cabotegravir study that just finished. It's one of the HPTN trials. They did it in both men, and then they also did it in cisgender women. And both of those trials were compared to FTDF as the gold standard, as opposed to placebo, because it's no longer ethically acceptable to compare compared to nothing in condoms, given that we know we have an effective alternative.
Right.
But yeah. So condoms are always great because even the most effective PrEP is only going to protect against HIV, not against gonorrhea or chlamydia or syphilis or the whole host of bugs that are out there. But realistically, we know that most couples and most people don't like using condoms, and we have to meet people where they're at and make sure that people are doing what they're doing in the safest way possible. But not shame people for the choices that they're making.
The studies are still approved, though, recommending condom use.
Yeah, I mean, I think the same way clinically we recommend condom use, studies also recommend condom use, and a lot of them will pass out condoms, but there's no longer compared to condom use alone, and there's no condom mandate. The Partners Demonstration Project and the Partners PrEP studies specifically looked at PrEP in serodiscordant couples, so both heterosexual and gay couples who were where one partner had HIV and the other partner did not. And there's a lot of data to show how effective PrEP is, but also how effective having a partner with a suppressed viral load also is, which is referred to as undetectable as untransmittable, or U equals U. So there's been a lot of changes and a lot of really positive changes in the way we think about HIV prevention and the way we think about how to study HIV prevention.
I have a question. Thank you, Rachel, for the presentation. How about the medication adherence, especially for prevention? So I know mostly these populations might be difficult to work with. And then they may get on the medication, but they may not stay on the medication. So do the drugs work if patients, for instance, instead of taking it every day, take it every other day, or
So in men, it works. In women, it doesn't work as well because the tissue levels don't get quite as high. It's still better than nothing, but it's not as effective. And that's why really it's not, I'm a gynecologist, right? So it all comes, I bring everything back to gynecology. It's not that different than birth control pills. People are bad at taking a pill every day. And women, for the most part, are bad at taking a birth control pill every day. That's why we invented IUDs and the Nexplanon implant and the Nuva vaginal ring and the Depo shot. We have tons of options of contraception, and PrEP is only now catching up to that by thinking outside the box and not just offering people a pill, but offering them things that work better with their lifestyle. It's really challenging, even for those of us that are hyper organized, to do anything at the same time every day. And so I can't blame people for not taking their pills perfectly. I was on antibiotics a couple of months ago. I had to set an alarm or I couldn't remember. So it's really challenging, and it's even more challenging, as I mentioned, when it's for something you're not feeling or noticing. I took my antibiotics for my sinus infection, but the second I started to feel better, I had to set the cell phone alarm or I was going to forget to do it. And it's the same thing with anything preventative. If it's not in your face and bothering you, it's human nature to kind of push it away and, get busy with, your kids and your job and your everything else. So, yes, I think adherence is going to continue to be a big issue with anything that's a pill. That said, I do believe in choice, and I believe in I don't think we should throw pills out the door. I think having pills for people that want to take pills and are good at taking pills is great. And I think especially in situations like pregnancy, where we want something that is potentially shorter acting, granted, we do need to look at dosing, but where you might want something that's shorter acting, you might not want to be on a 2-month pill, a 2-month injection while you're in pregnancy, especially when you don't know what that looks like. But I think giving women and giving all people the full gamut of prevention options and seeing what works best with their lifestyle and their personal desires is, I think, the way to go. And it's the direction that things are moving in.
Thank you.
Okay, if we don't have any questions in the box, I'll move on to the next part, but please continue to put your questions in the chat box. It could be for Dr. Scott's talk, my talk, or any of the above. And we should
Thank you so much for your questions. Thank you.